to Hadassah on Call, New Frontiers in Medicine. I'm your host, Maayan Hoffman. Asthma is a chronic lung disease that makes it hard to breathe. According to the World Health Organization, symptoms can include mild or severe coughing, wheezing, shortness of breath, and chest tightness. Asthma usually means swelling or inflammation inside the lungs, making a person more sensitive if exposed to viruses, allergens, or other irritants. According to the Asthma and Allergy Foundation of America, around 26 million Americans have asthma. That's 1 in 13 people. Asthma is a growing medical problem in Israel, too. It affects at least 7% of children and 3.7% of the population. Researchers have recently discovered that asthma could lead to a higher risk of arthritis, food and seasonal allergies, and could make you more susceptible to eczema. It can also lead to sleep disturbances. To discuss asthma, we have with us today Dr. Joel Reiter, head of Hadassah Medical Organization's sleep clinic. Welcome, Joel.
Hello.
So, this is actually your second time on our podcast. You've been with us before, and last time you were here, we discussed sleep disorders. Today, though, we're going to discuss an issue that actually sometimes contributes to sleep disorders and additional other negative impacts, and that's asthma. So just to make sure our readers understand really what we're talking about and who we're talking to, can you tell us just a little bit about yourself and specifically your role at Hadassah?
Yeah, sure. So my name is Joel. I studied medicine here in Jerusalem, and then I continued for a residency in pediatrics here in the pediatric department in Hadassah. I then continued for a fellowship in pediatric pulmonary in Miami, and I completed that with a fellowship in sleep medicine in Boston.
Amazing.
I've always wanted to be a pediatrician. Or the legend says that when I was 5 years old for Purim, I dressed up as a doctor with my ankles. They somehow made his robe smaller, so I wore that. And I know that since then, at least, I wanted to be a pediatrician. Then pulmonary came because I found it very interesting in med school, and then sleep was just fascinating and a niche that I found interesting in pediatric pulmonary.
And it's interesting how they go together. So as we mentioned, the topic of today's show is asthma. And tell me a little bit about what is asthma and what are the general ways that it can affect our everyday lives?
Okay, so asthma is the most common non-infectious disease in children. It affects about 9-10% of kids. It's also very common in adults. And it's a disease with variability and inflammation of the airway. So we can have patients that are totally perfect one day and have an asthma attack the next day. Whereas we can have other patients that continuously have problems, but there's a lot of variability, both in the presentation and then with ongoing disease on how it appears or how it affects their life.
So, tell me a little bit about how we know whether or not it's going to be severe, and what kind of things contribute to that. Like, is it diet, exercise, for example, that plays into how well we're feeling which day?
Okay, so that becomes a bit complicated. So we used to divide asthma into patients with severe and less severe and intermittent and continuous asthma. And we're trying kind of taking a step backwards from that because we know that even patients with mild or intermittent asthma that don't have a lot of exacerbations can have very severe exacerbations and end up in the hospital ICU, etc. So we're kind of taking a step back from that. But what we try to do is when we see the patients for the first time, kind of determine the severity of their disease, start treatment, and then we do what's called step up, step down. So if we manage to control their disease, we're happy with what's going. If we're not controlling the disease, then we take a step up and we add medications or increase doses. Now, a lot of things can affect how stable or unstable or how controlled your asthma is. And definitely several of the things that play into that are stuff like you talked about.
Like the diet and the exercise, things like that. Are there any particular parts of the things that I were mentioning that are more profound than others in terms of the impact?
So when we look at patients nowadays, we're trying to phenotype them or to do what's called personalized medicine. And when I teach students, I tell them that's the difference between what I do and what you're going to do. When we see an asthmatic patients, we mostly start with the same kind of medications. What we expect there to happen in the upcoming years is we'll be able to better define their specific asthma phenotype or what group of patients they belong with and what's the specific treatment that will help them the most. In some patients, what plays as a factor is, for instance, exercise or food. For instance, patients that are obese suffer from worse asthma. there's a dose response. The more obese you are, the worse your asthma is, the worse it is controlled. Some patients are allergic. If you have allergic asthma, then we want to figure out what you're allergic to and try to control that.
And how would you do the testing for that? I mean, maybe this is a naive question, but somebody comes in, do you say, oh, clearly your diet is wrong? Or how do you end up figuring out that it's the diet? Or obesity is maybe a little more obvious, but how would you know to take the allergy test?
So some of it comes just from the history. So we ask the patients, do you have a history of allergies? Is there a tendency for atopy or allergy in the family? For instance, if the parent is allergic and has hay fever, the child might be allergic to something else and have asthma. So if there is a tendency for asthma, for allergies in the family, then we know that might be playing a factor. And then, for instance, I refer a lot of my patients to allergy doctors to do allergy testings. In Israel, as pulmonologists, we can't do the allergy test, but we will refer them to their allergy doctors. They will do the allergic testing, and then they'll come back to us to try and better control their asthma, knowing what they're allergic to and what needs to be controlled from that perspective.
And I know this maybe is a naive question, but in terms of physically, when you do x-rays or MRIs or anything in order to see what's actually going on inside the lungs, and does that contribute at all to either diagnosis or to understanding the severity?
So we do pulmonary functions where you blow into a machine. Now, it sounds very simple, but you need quite a lot of coordination and the ability to do it. It's not that simple. But starting at the age of 6, more or less, we can do pulmonary functions and try to figure out what are the airflows. And then some of the asthmatic patients are continuously obstructed and they don't know about it. And then it will come up on these pulmonary functions. In other asthmatics, because of the variability in their presentations, they might be totally perfect between exacerbations. And then we would need to do trigger tests or challenges. There's challenges that we do with exercise. There are challenges that we do with inhalations, where it gives something that will irritate their airway. And we know that asthmatics get irritated faster and worse. So we can try to determine that way whether patients are asthmatic. And now for infants, it's more complicated. So like I said, we need to be around 6 years old to do pulmonary function tests. Way back a few decades ago, they developed infant PFTs, which is kind of a box where we put babies inside the box. They get mild anesthesia so that they're sleeping. And then we can imitate blowing forcefully with a vest that they wear and check. And that's one of the tests that was developed here in Jerusalem.
It's used worldwide now after the
So it's used worldwide. It was developed in collaboration. It was mostly Australian pediatric pulmonologists and Israeli ones, but it's one of the things that a lot of people came to study pediatric pulmonology here at Hadassah. So we can also learn and gain insight about the patients and what's going on with them in the young ages with this testing. And nowadays in Israel, it's only done here at Hadassah. So we get referrals from all over the country.
Oh, and why is it only done here at Hadassah?
Because it's a complicated test, it requires time, it requires expertise. So it was developed here. So this is the center that covers in Israel. For instance, if I need to think, so I learned pediatric pulmonology in Florida, in Miami. If you wanted to do infant pulmonary functions there, I think we needed to send the kids over to North Carolina. So it's complicated. It's not done everywhere, and you really need the expertise to be able to do this.
And are you the only one that does it here, or are there multiple doctors?
No, so there's one that's actually not me. It's another doctor in our team that does this, but we all use his services.
Incredible. So tell me a little bit about the importance of controlling the environment. So we talked about different triggers. Also, I know dust and other things can be triggers. How important is it for an asthmatic to sort of watch what's happening around them in order to ensure that there isn't some kind of upset?
So we need to figure out what's the trigger that activates their asthma. So for instance, just last week, I had a phone call from a patient that told me that they went to the allergy testing that I sent them, and lo and behold, the kid has an allergy to a dog. They have a dog. And then the question is, okay, what do we do? And I always joke with parents that I think parents will get rid of their kid before they get rid of their dog.
Is that what happened?
I hope not. But they decided, so the question there is a balance. How much treatment does the kid need to have his asthma symptoms at a minimum? And if we manage that, then he can stay with the dog with the price of being on chronic medications that have some side effects. They don't have a lot of side effects, they're pretty minor, but you're still giving a chronic medication.
What are some of the side effects?
So, for instance, one of the medications that we use often is inhaled corticosteroids. When you use them by inhalation, you don't get a lot of side effects, but when they checked kids for years and years of treatment, they showed that they were a bit shorter. And I always say that I am an asthmatic from Haifa. I am 1.58 meters. I don't know how much that is in feet, but it's not a lot. And I would have given up 1 centimeter to be able to be in more activities in high school that I missed because of my asthma. The rest of the side effects are pretty rare and we see them here and there, but that's the major thing that we warn patients
It
about.
actually stunts your growth.
A bit, yeah.
It's fascinating. So tell me a little bit about some of those limitations. You mentioned you'd like to be involved in more activities. So what kind of activities can and cannot asthmatics do?
So we want to get to the point where asthmatics can do anything they want. And I always go back to examples, and I think I'm getting too old. So the examples I bring up are soccer players, football players. So David Beckham is a known asthmatic, and there's photos of him standing next to the field with his albuterol or Ventolin inhaler. Michael Jordan, I think, was asthmatic, or that's at least what Google says. So we want people to be able to do as much as possible and supposedly everything. We don't want them limited because of their asthma. Now, of course, we can't get to that with all of the patients, but at least we try, and that is our aim. Some of our patients, their asthma is triggered by exercise. So they will get an asthmatic attack because of their exercising. But then what we can do is treat right before they go for exercise and control that way. And then we want them to be able to do what happens if you don't control their asthma. You end up having couch potatoes and they gain weight, they stop doing exercise, or they do even less exercise, they gain more weight, their asthma becomes less controlled, and then you get into this cycle. So we want them to try and be able to do everything.
Now, you deal specifically, as you mentioned, with sleep disorders. And we talked about that a little bit at the beginning, that there is actually a correlation between asthma and sleep. So why would asthma impact sleep?
So there are several reasons for this. One of them is that asthma gets worse during the night. So a lot of our patients have nocturnal symptoms. They will come in because the child isn't sleeping well because he's coughing at night. So asthma is linked with insomnia. So you just don't sleep well because your asthma is bothering you. It also works the other way around. If you're not sleeping well, your asthma will be less controlled. And then there's specific fields inside sleep medicine that have correlations with asthma. So for instance, sleep-related breathing disorders or obstructive sleep apnea. That's obstruction of the upper airway, whereas asthma is obstruction of the lower airway. It's the same tissue, basically. So we think there's a correlation between the two because of a common pathophysiology. What drives one probably also drives the other. And the other thing is a lot of them have very similar comorbidities or risk factors. For instance, if we go back to obesity will make you more prone to asthma, will make your asthma less well controlled, and you're more prone to having obstructive sleep apnea if you're obese.
Does asthma cause you to snore?
So asthma doesn't directly probably cause you to snore. Or when we look at causality, we're not sure there is causality between asthma and obstructive sleep apnea. So it's not that one causes the other. Snoring is the mild range of sleep-related breathing disorders. So you can call it mild obstructive sleep without the apnea. But snoring comes from inflammation of the upper airway in children, mostly from tonsil and adenoid tissue. And what drives that is inflammation. And what drives asthma is inflammation. So because inflammation drives both of these processes, then you can get one and the other, and one affects the other. So the 1 and 1 equals more than 2 eventually.
Interesting. Can you give any general, everyday tips that could help people who are suffering from asthma be able to sleep better?
So if you're not, so it goes in a few. So if you're not sleeping well and you have asthma, we need to try and figure out why aren't you sleeping well? Is your asthma not controlled well enough, and we need to increase your asthma treatment? Or do you also have sleep-related breathing disorder, and do we need to treat that? And treatment of obstructive sleep apnea is pretty simple in children. It's simple surgery. So we want to know that the patients are snoring and that they might have obstruction, and then treat that. And by treating that, we might improve their asthma as well. And the first thing that needs to be done is the physician needs to ask the patients whether they're snoring or their kid is snoring. We recently published a review paper where we looked at the connection between asthma and sleep disorders. And the bottom line, our conclusion was that we hope that we convinced physicians treating asthmatic patients that they need to ask the patients about their sleep.
Sounds like a lot in some ways is chicken and egg, like the asthma causes this, and then this can also cause an asthma attacker to be worse. Is there also a correlation between asthma and allergies?
So some of the asthmatic phenotypes are allergic. So some of the people what drives their asthma is allergy.
But is it like a direct correlation?
So with them, so like I said, some people that are allergic will have hay fever, some will have skin infection, some will have asthma. And then what drives their asthma is the allergic reaction, or what we now call Th2 responses, the cells that are interacting there. And what we've come to these days, or the past few years, is biologic treatment.
It's that.
So whereas we used to have severe patients that were on chronic medication and chronic steroids, now we are able to try and halt the allergic response at a specific point so that we don't affect their inflammatory system as a whole, but we affect a very specific point. And with that, we are now able to control asthma with injections that are usually given every 2 or 4 weeks, depending on what specific medication and where we want to try to treat them. And so what we do when we see patients, we test them for tendencies for allergies. We check the immunoglobulin that's in charge of allergies. We check for eosinophil cells, which are the cells that are involved in allergies. And if those are high or positive, then we have the possibility of aiming treatment at that.
You mentioned that you're doing testing as young as in infants inside of the special box. I mean, is asthma something that you could have when you're young and actually grow out of?
Okay, so the answer to that kind of depends on the phenotypes. So some of the asthmatics will be mostly asthmatics in the younger age, and then they'll kind of grow out of it, while others it will be different. And so some asthmatics are only diagnosed when they're adults. But for instance, I always go back to myself. So I was a pretty active asthmatic when I was a teenager. I haven't had an asthma attack for, I think, a couple of decades. When I cough nowadays, I walk next door. I go into the pulmonary function lab because I'm a bit of a hypochondriac. I check myself and I see that my flows are normal or close to normal. So I grew out of my asthma. There can be several reasons for this. For one thing, I grew up in Haifa and now I live in Jerusalem.
There's a lot of pollution in Haifa.
Yes, exactly. So there's a lot of pollution there, but there's also humidity. So dust might, for instance, thrive on humidity. Jerusalem is drier, so it's a bit easier from that perspective. So some will grow out of it, some will not. We see more asthma in boys, in young children. We see more asthma in women as in adults. So it kind of changes along the time.
With the women, is it tied to fertility at all or pregnancy?
So you'll have to ask an adult pulmonologist. I'm not sure. I think mostly so inflammatory illnesses are more common in women, and I think that's why it increases when they grow. And then when we go back, so for instance, if you're allergic, if you move to somewhere where there aren't those things that you're allergic to, your asthma will get better. If you're obese and you lose weight, your asthma might go away, and that's mostly studies in adults. So we know that some obese asthmatics will totally grow out of their asthma if they lose weight, while others will stay asthmatics. So for them, probably the effect is more allergic or inflammatory or something else, and doesn't have anything to do directly with the obesity.
Artificial intelligence, genetics, there's a lot of new technologies coming out. You mentioned about moving toward personalized treatments. Are any of these new technologies that we're talking about that are really just starting in the healthcare to create a revolution? Are any of these involved in the work that you're doing, or do you envision them being involved?
So they're not involved that much yet. I think they will definitely come in, both in trying to understand what our patient is presenting or what his specific phenotype is, but also with treatments, things that are as simple as how do you make sure that the patient takes their treatment, takes it correctly? So we have now apps that will remind you to take your medications. But as we move forward, these apps will be smarter and smarter. So they won't only check that you're taking the medication, they'll check that you're doing it correctly. They'll check your effect. You can, for instance, put in scores to how your asthma is controlled or not controlled. I still give patient asthma diaries where I ask them to fill out on a piece of paper, put it on the fridge, and fill out every day how active their asthma is. But you can do this today with apps, which are simpler, and the app will remind you that you need to do this, and you probably won't forget to bring your phone to the doctor's appointment, whereas people do forget to bring the paper that they left on the fridge.
Of course. So is there any research that you're working on right now, or any studies that you're working on that you want to share?
So right now, I'm not doing any study specifically on asthma. One of the last studies that we did was looking at rates of admission for asthmatic patients in Israel. And what we'd shown was very interesting is that over the past 2 decades, there's fewer and fewer patients that are admitted with asthma, and it got to a point where it was kind of plateauing. So we need to understand what's causing this plateau. So why aren't we still going lower and lower? The other thing that we'd shown was that the rates of asthma admissions were very different in different regions of Israel. So for instance, Jerusalem always had a low rate of asthma admissions compared with Haifa or Tel Aviv. We saw improvement in all of these regions, but the improvements were much bigger in places that had higher rates of asthma. So Tel Aviv has improved dramatically.
What explains that?
So some of it is better control, better treatments that we're having, better understanding of what causes asthma and how to treat it. Some of it is air pollution. It's probably that the Haifa area is less polluted than it used to be.
Really?
Things are changing. We would like it to be even less polluted. And when we started off the study, one of the aims was to show that what we've done, the way we've cut air pollution, isn't enough. And that might be one of the things that's causing this plateau. So maybe if we decrease the pollution even more, we'll get Haifa patients to be as good as their Jerusalem counterparts.
And Jerusalem has maintained its level? And
so it also got better in Jerusalem, but it was much lower to start with, and it's still much lower than it is in many other regions of Israel.
Is there anything else you want to add? Anything else you think people should know that we didn't talk about?
So every now and then we get an older patient or an older teenager where they suddenly discover that they're not sleeping too well, they're coughing at night, or they're having trouble with exercise that they weren't too aware of before. And we bring them into the pulmonary function testing lab and see that their pulmonary function tests show that they have asthma. And this is something that was missed for years, and probably they just got used to their symptoms and thought that was how they breathe, how they're supposed to live. So we miss patients here and there. Israel has the advantage of the army. So because a lot of people go screening for the army picks up on many of these things. But these patients, if we had been controlling their asthma from a younger age, they would have gotten to their adult life with better quality of life. Knowing what they have, we might have prevented previous exacerbations that they had bore that. And we can now treat them and treat them better. So if you're coughing at night, if you have short of breath, if you have trouble with exercise, as a parent, your kid or yourself as an adult or teenager, then have asthma tested. You asked me before how we check for asthma, so we mostly do pulmonary functions, but before that, we listen with our ears and hear whether the patient is wheezing. And then we'll have patients here and there that you can hear them wheezing very clearly, and it's just that they didn't complain, so nobody actually listened and knew.
Well, thank you so much for being with us today, Dr. Reiter. I really appreciate it.
Thank you.